Welcome to the Explainer. In this masterclass, we're going to do a deep dive into the clinical foundations of Parkinson's disease, really bridging that gap between the fundamental science and how we actually diagnose and manage this complex condition in practice. Okay, so here's our game plan. We're going to build this up logically, step by step. We'll start with the absolute core definition of the disease, then we'll look under the hood at the underlying brain pathology. After that, we'll get into the nuts and bolts of how it's diagnosed, what other conditions can look like it, and we'll finish up with the key principles of management. First off, let's just ground ourselves in how common this is. Parkinson's is not some rare, obscure disorder. We're talking about a condition that affects a significant 2 to 3% of the population by the time they hit their 80s. That makes it one of the most common neurodegenerative conditions you'll encounter in medicine. All right, section 1, what exactly is Parkinson's disease? When we're in the clinic, what are the specific, concrete signs that we're trained to look for? So, the condition, which was first properly described way back in the 1800s, is defined by what we call a cardinal triad, 3 core clinical features. And I'll tell you, mastering how to spot this triad is absolutely fundamental to making an accurate diagnosis. The first and honestly the most important feature for the diagnosis is bradykinesia. Now that literally translates to slowness of movement, but it's a very specific kind of slowness. We're looking for a progressive reduction in both the speed and the size, the amplitude, of repetitive actions. What you'll see is the movement actually gets smaller and slower the more the person does it. It just deteriorates. The second feature is a resting tremor. Now, a tremor is just a rhythmical, predictable oscillation around a joint. But the key word here, the one you absolutely have to remember, is resting. This tremor is most obvious when the limb is completely supported and not being used for anything. And often it'll get better or even disappear completely the moment the person goes to do something. This is what really helps us distinguish it from other kinds of tremor. And number 3 is rigidity, which is an increase in muscle stiffness. Now, it's really critical to distinguish this from spasticity, which you might see after a stroke. You see, spasticity is velocity dependent. It gets worse the faster you try to move the limb. The rigidity in Parkinson's, on the other hand, is a constant lead pipe kind of stiffness that's there throughout the entire range of motion, no matter how fast or slow you move it. Okay, so we know the what, the clinical signs. Now let's explore the why. What is actually happening in the brain? What's the underlying neurodegenerative process that makes these symptoms show up in the first place? So, Parkinson's is what we call a neurodegenerative disorder. This means its symptoms are directly driven by the progressive death and dysfunction of nerve cells. This is a really important distinction from other neurological problems like, say, multiple sclerosis, which is caused by inflammation or damage from an infection or an injury. In neurodegeneration, the brain tissue itself is slowly and, unfortunately, irreversibly lost over a long period of time. Now, here's a concept that is just absolutely crucial to grasp. This neurodegenerative process is incredibly insidious. It starts long before the classic motor symptoms ever appear. We're talking 10 to 15 years, where a patient might only have what we call prodromal symptoms, things like constipation or a particular kind of sleep disorder. This means that by the time someone walks into the clinic with a tremor and we make that diagnosis, at least 70% of the key dopamine-producing neurons have already been destroyed. And if we zoom right down to the microscopic level, Parkinson's is classified as a synucleinopathy. It's a bit of a mouthful, but it refers to diseases caused by the abnormal clumping of a protein called alpha-synuclein. Inside the neurons, this protein misfolds and sticks together, forming these toxic clumps known as Lewy bodies. These Lewy bodies are the pathological hallmark of the disease and our primary reason the cells die. So, how do we put all this together in the real world? Well, the diagnosis of Parkinson's is, in the vast majority of cases, a clinical one. What that means is it relies on a skilled history and physical examination. There's no definitive blood test or brain scan that says, yes, this is it. The whole examination really hones in on finding that cardinal triad. We test for bradykinesia with repetitive movements like tapping fingers together, and we watch for that classic decay in speed and size. We look for a resting tremor, and we can often bring it out more by distracting the patient with a task in their other arm. That's a little technique called the lesser maneuver. For rigidity, we'll passively move their arm or leg, feeling for that smooth, constant lead pipe resistance, or maybe a jerky, ratchet-like cogwheel feeling. We also keep an eye out for other supportive signs, like a masked, expressionless face, a stooped posture, or seeing them take extra little steps when they try to turn around. You know, one of the most powerful supportive features for a diagnosis isn't a test at all. It's the patient's response to treatment. While it's not a formal diagnostic criterion, seeing a dramatic and sustained improvement in motor symptoms after starting dopamine replacement therapy, well, that's a very, very strong indicator that the underlying problem is indeed idiopathic Parkinson's disease. It really helps confirm that dopamine deficient state. Right, so here's a crucial point. Not everything that looks like Parkinson's disease actually is Parkinson's disease. And this brings us to the really important concept of the differential diagnosis. And this is where we have to be super precise with our language. Parkinsonism is the broad, descriptive umbrella term for the clinical syndrome, that combination of bradykinesia, rigidity, and tremor. In contrast, idiopathic Parkinson's disease, or IPD, is the specific diagnosis of the most common neurodegenerative disease that causes that syndrome. So you can see, lots of things can cause Parkinsonism, and IPD is just one of them, albeit the most common one. This framework is really helpful for organizing our differential diagnosis. We can split the causes into two main buckets, primary and secondary. The primary causes are the neurodegenerative ones, with IPD being the most common, followed by these rarer but important atypical Parkinsonian syndromes. Then you have the secondary causes, which is when Parkinsonism is the result of some other external factor, like certain medications or vascular disease in the brain. So in any patient who presents with Parkinsonism, we are constantly on the lookout for red flags. These are clinical features that suggest the diagnosis might be something other than standard IPD. Finding these red flags often points towards one of those atypical syndromes, which tend to be more aggressive and have a worse prognosis. Some key red flags to watch for are symmetrical symptoms right from the start, unusually rapid progression, a poor or non-existent response to dopamine therapy, and the early appearance of severe problems like falls or autonomic dysfunction. The first atypical syndrome to know is multiple system atrophy, or MSA. Pathologically, just like Parkinson's, it's also a synucleinopathy. The clinical red flags that scream MSA are the early and severe onset of autonomic failure. I'm talking about things like profound drops in blood pressure when standing up or severe bladder problems. Another key feature is the presence of cerebellar signs, which cause problems with coordination and balance, along with a very characteristic high-pitched, noisy breathing sound called laryngeal stridor. Next is dementia with Lewy bodies, or DLB. Pathologically, it's a very close cousin to Parkinson's. It's also a synucleinopathy. But the defining red flag here is all about timing. In DLB, significant dementia happens right up front, within the first year that the motor symptoms appear. These patients also tend to have early, very vivid, and well-formed visual hallucinations, and they can be extremely sensitive to certain antipsychotic medications. Now, DLB actually exists on a spectrum with something called Parkinson's disease dementia, or PDD. At a pathological level, they're really the same disease. The distinction we make is totally arbitrary, and it's based purely on a one-year rule. If the serious cognitive decline happens within 1 year of the motor symptoms, we call it DLB. If it develops after more than a year of established motor Parkinson's, we call it PDD. Together, they make up the Lewy body dementias. All right, let's switch gears a little. Next up is progressive supranuclear palsy, or PSP. Now, the underlying pathology here is different. PSP is a tauopathy, which means it's caused by an abnormal tau protein, not alpha-synuclein. The classic red flags for PSP are 1. Early falls, often within the first year or two. 2. A severe rigidity in the trunk and neck, what we call axial rigidity, that gives them a very stiff, eyes-wide-open stare. And 3. A very characteristic problem with eye movements called a vertical gaze palsy, which is an inability to look up and down properly. And finally, we have corticobasal syndrome, or CBS, which is also a tauopathy. A key feature here is that it's often strikingly asymmetric, affecting one side of the body much more than the other. But the really unique features are what we call cortical signs, which reflect dysfunction in the brain's cortex. This includes things like apraxia, where someone can't perform a learned movement like brushing their teeth, even though they have normal strength. And sometimes this very bizarre alien limb phenomenon, where a hand or arm seems to move with a mind of its own. Okay, so let's move on and talk about investigations. How can modern imaging actually help us support a clinical diagnosis, especially when the picture is a little bit murky? A really useful tool here is the data scan. It's a specialized brain scan that lets us visualize the dopamine transporter system. In a healthy brain, the image has this distinct, bright, comma shape. But in someone with a primary dopamine problem, like Parkinson's, that comma is lost and it degenerates into more of a period shape. This can be incredibly helpful to confirm there's a true dopamine deficit and to tell it apart from things like drug-induced Parkinsonism or essential tremor, where the scan would look completely normal. And what about a regular MRI? Well, while we don't use it to diagnose typical Parkinson's, it can sometimes show us findings that support one of the atypical syndromes. For instance, some patients with MSA might show what's called a hot cross bun sign in a part of the brainstem called the pons. Similarly, some with PSP show a pattern of atrophy in the midbrain that looks like a hummingbird sign. But, and this is a really big but, it's crucial to remember that these signs have low sensitivity. That means they're often absent even when the disease is present, so they're supportive clues, never diagnostic on their own. Okay, finally, let's talk about the principles of management. And it is so important to understand that managing Parkinson's is about so much more than just prescribing medication. The absolute cornerstone of high-quality care is the multidisciplinary team, or MDT, and the person at the very center of that team is always the patient. The core team is usually a neurologist and a Parkinson's disease nurse specialist, but they're supported by a whole crew of essential therapists: physiotherapy to help with mobility and balance, occupational therapy to help with daily function, and speech and language therapy for voice and swallowing issues. Then you have a wider network of specialists who can be brought in as needed. Over time, as the disease progresses, patients on dopamine therapy can develop what we call motor complications. This often starts with something called wearing off, where the effect of one dose of medication doesn't last long enough to get them to the next one. This can then evolve into unpredictable on-off fluctuations, where the mobility can just suddenly switch from good to bad, and eventually, many develop dyskinesia. These are excessive, involuntary, often dance-like movements that are actually a side effect of the treatment itself. To manage these complex motor fluctuations, we often have to turn to more advanced device-aided therapies. The goal of all of these is to provide more continuous, steady, dopaminergic stimulation. The main options include subcutaneous pumps that infuse a drug continuously under the skin, intestinal gels that deliver levodopa directly into the gut through a small tube, and deep brain stimulation, or DBS, which is a neurosurgical procedure where we implant electrodes into the brain to help modulate the movement circuits. And finally, it is so vital to remember that Parkinson's is much, much more than a movement disorder. The non-motor symptoms can be just as disabling as the movement problems, if not more so. We're talking about a whole range of things, from autonomic problems like constipation and drops in blood pressure to a whole host of neuropsychiatric issues like sleep disturbance, mood changes, anxiety, and cognitive problems. Managing these is an absolutely critical part of comprehensive care. So, to wrap this all up, idiopathic Parkinson's disease is the most common cause of the clinical syndrome we call Parkinsonism. The diagnosis is clinical, but we always have to be on the lookout for those atypical mimics. And management is a complex, team effort to address both motor and non-motor symptoms. This leaves us with the critical billion-dollar question for the future. Given that we know this disease process starts more than a decade before symptoms even show up, could we one day find a way to diagnose it and intervene in that silent phase before all the damage is done? That is the holy grail.